G'day guys, welcome to the ACL Survival Club. My name's Alex, I'm a professional rugby physio and I've been rehabbing Charlie, who's a pro rugby player. We're at 6 weeks post her ACL reconstruction with her patella bone graft, and I'm going to take you through my best tips for ACL rehab in the first 6 weeks and also show you exactly what Charlie has been doing in her rehab as a full-time athlete. And I'm really going to try and put this into context so hopefully it can help to educate you and get you to make better decisions around your ACL rehab. This advice is useful for people that have had a hamstring graft, a patella bone graft, or if they've had a quadriceps graft. Charlie has not had a meniscus injury this time around, so therefore we don't have to worry about non-weight bearing. If you are someone that has had meniscal repair, a chondral injury, or multiple ligament injuries in your rehab, likely you'll have different timeframes in the first 4 weeks, such as being non-weight bearing or being in a brace in the first 4 to 6 weeks post-surgery. Most meniscal repairs are in a brace at 0 to 90 degrees for the first 4 to 6 weeks, and they're also non-weight bearing. Also non-weight bearing for chondral repairs for the first 4 weeks, and many multiple ligamentous injuries. So if you've done your posterolateral corner, your MCL, your LCL, be in a brace for that first 0 to 6 weeks. Right off the bat, the most important thing I can tell you is to get the knee straight. Getting the knee straight, no matter what graft you have, is the most important thing that you can do, and nothing else matters until you get that knee straight. It's not something that is like, oh, it's kind of straight. It has to be straight. The reason for this is that you can't run or walk if your knee is off extension. If you are off extension, you'll load your kneecap. Your fat pad that lives underneath there, that patellofemoral joint where the kneecap runs through, is going to get sore. Your muscles will be inhibited. You won't get your VMO back, and you will not be able to have a successful return post ACL. This is the single most important thing for you to achieve post-op. And we should be able to realistically achieve this inside the first 1, if not first 2 weeks. Secondly, we want to protect the graft. It's really important that we protect the graft that has gone in, so the replacement ACL. That could be the patella tendon, that could be the hamstring tendon, or it could be the quadriceps tendon. And that will be by wearing the brace if you've been indicated to wear the brace. We also want to protect the donor site, so where that graft came from. So for the patella tendon that Charlie has had, we've been really making sure that we don't do straight leg raises because that will affect the patella tendon. We don't kneel on it. We don't touch it too much. We're really just trying to let that settle and let that infill, because they take a big chunk of that patella tendon out, and we want to make sure that it really starts to heal, starts to scar up, and it'll start to infill and become a normal patella tendon again. With your hamstring, you've had essentially a full grade 3 rupture of some of those hamstrings when they do the graft. So it's really important that we protect you from doing multiple restrains of that hamstring throughout the first 6 weeks. Most people will get a pop at some point during their rehab because of the scar tissue that's laid down, but we want to protect that hamstring site, and the same can be said for that quadriceps tendon. Number 3, you really can't win your rehab inside the first week. No one has ever returned to sport inside the first week, so don't boom and bust. We want to string as many good days together as possible. If you've had a good day, that doesn't give you permission to the next day do twice as much as you did the day before. We want to compound interest, string as many good days together as possible, and this is going to give you the best chance of having success early on in rehab. Part of this is checking your knee in the morning. Is it more hot than yesterday? Is it more sore than yesterday? Was it more stiff in the morning than it was yesterday? If it is, chances are you've done a little bit too much the day before and you need to reduce. So stay consistent with your swelling management. Keep wearing your compression. Keep elevating. Keep using your ice, be that with the game ready. Keep using your compex. Reduce your step count. Tracking your steps is really important. Keeping it below 3,000 steps a day is a really nice way to make sure that we're not loading that leg too much. Charlie, for example, has been able to weight bear since the first day of surgery, but by reducing our steps, we'll reduce the amount of load going through Charlie's knee. This will reduce the amount of swelling that she's getting. By reducing the amount of swelling, the quads will be able to switch on better, because if you have too much swelling in the knee, the quads just can't switch on. She'll be less sore, able to do her exercises, able to do her range of motion exercises, get that knee straight, get that knee bent, and then we'll be able to get on with our rehab as the weeks progressed. And a lot of people say, well, I don't want to lose muscle bulk. You are going to lose muscle bulk. That is just a fact of ACL rehab. And that is why we do an extensive prehab before surgery where possible. That is why training year round is great for preventing injuries. But post-op, we are going to lose muscle. In the first 0 to 2 weeks, we can't use occlusion because it can affect the body negatively. Some people do use it after 3 days, but after 2 weeks, the contraindications for most people in using occlusion training does go down, and that's when we started it for Charlie, was after 2 weeks. By using the compex and doing maximal quad sets at least once a day, we've been able to make sure that muscle is switching on, which will help to reduce the amount of atrophy that occurs. And we were able to get really good muscle activation by getting the knee straight, which I spoke about before is the most important thing. Because her knee can get straight and because her knee is not swollen, that knee is able to contract properly and maximally with the help of the compex. This means the muscle is working hard and it won't atrophy as much. We were also able to use metabolic stress via the occlusion, which means essentially we are giving her the pump, we're giving her that lactic acid buildup in the muscle. The rate at which her muscle bulk atrophies is going to reduce, and hopefully at some point at the 6-week mark, we're actually going to start inducing muscle growth and actually stop that effect of that muscle wasting away. We can't induce a lot of muscle growth inside the first 6 weeks, but that doesn't mean that rehab is useless. When we go back to run, a lot of things need to be good. Our foot control, our foot movement, our ankle strength, our calf strength, our hip strength, our hamstring strength, our core strength, our coordination is all really important when it returns to run. It is not just all about the knee, it is not just all about the quad. A lot of things that we can do can be done maximally very early on in rehab. There is no reason we can't train the glutes, the lateral hip, our hamstrings if you had a quad tendon, our quad if you've had a hamstring, our calves, our ankles can be loaded at a high level. These things should already be where they need to be to allow us to return to run. And then the last thing that we are waiting for is just getting that quad, getting that knee to switch on, getting those muscles in the quad back. That will allow us to then return to run at that 16 to 18 week mark. We don't want to sweat too much inside the first 2 weeks. Now you'll see that Charlie did a lot of rehab in the first 2 weeks, but she wasn't trying to sweat too much because there is wounds in the knee. One of the worst things that you can do is get a knee infection. This will derail your rehabilitation completely and may lead to some very serious complications. Best to stay at home in a clean environment, not sweating too much, and do your rehabilitation from home. Big golden tip here is that in surgery, when they put those dressings on, it is surgically clean. Those dressings were put on in a very clean surgical theatre. Do not take them off. Do not peel them to have a look at the wounds. Keep them on until you get your 2-week follow-up and they take the stitches out and have a look at your wounds. Keep them on. One thing that I try to get across to a lot of people is use your crutches. Getting off crutches doesn't mean progression. It just means that you're going to load your knee more. Charlie, for the first 4 weeks, up until about day 29, she was using her crutches every single day for every step that she took. We want to make sure that when you're walking, your knee is straight. So coming back to having full knee extension, we want to make sure that you're getting around the house with the knee straight. You're not loading your joint up maximally by using no crutches. You want to use the crutches to take weight off the knee, which will in turn reduce the amount of swelling, which will mean that you get more muscle activation because you don't have as much swelling in the knee. Obviously, if you are non-weight bearing, definitely do not walk without crutches. In the first 6 weeks of Charlie Rehab, the first month is focused on protection and motor control, meaning we're making sure the knee is not getting injured, we're making sure that we're protecting it with the use of crutches, and we're also working on getting the knee moving, so getting control of that knee, switching the muscles back on. We are cognizant that in the first 2 weeks there's infection issues, so make sure that the knee does not get infected, we are not sweating too much, we are protecting those wounds. We're working on a lot of movement, getting the knee straight, getting the knee bending, and we're also making sure that we're recovering well with our swelling management. In weeks 3 and 4, we are starting to do a little bit more mobility, a little bit more strengthening, making sure we are doubling down on our swelling management, and we're keeping an eye on the early amount of loading that we're doing. We're not walking too much, and we're just starting to use those other muscle groups. So the glutes, the hamstrings, the quads are slowly doing a little bit more. The calves are doing a lot more. The ankles are doing a lot more, and we're doing a little bit of core strap. So we're not trying to do too much at any one point in time. We are trying to string good days together. And then in weeks 5 and 6, we're moving on to the second block. We're working on her gait, her introduction to gym, and working on a lot more atrophy prevention with the inclusion of blood flow restriction, etc. that started after week. We're trying to prep her for her return to gym, and we're starting to then do a little bit more reps with a little bit more load and just keeping an eye on how her knee is progressing day in and day out. So as you can see here, we are working on quietening the affected area, looking at her range of motion, neuromuscular control inside the first 6 weeks, meaning the knee is able to be controlled. We are working on introducing hypertrophy into our program. So we're starting to strengthen the opposite leg after 2 weeks when we're allowed to sweat. And we're starting to introduce the upper body after 2 weeks after we're allowed to sweat. I will only introduce opposite limb loading and upper limb loading once the knee has achieved what it needs to. So if the knee's not straight, I'm not getting someone to do their upper body. They need to keep their sole focus on getting that knee straight, because nothing else will matter if they don't get it straight. So Charlie was able to do that. So she was able to progress on to doing opposite limb strengthening, which is her opposite leg, and upper body lifts, because she'd achieved those key metrics inside the first 2 weeks. So in the first 1 to 2 weeks, we had Charlie's rehab. We were doing quad sets. We're doing the maximal one set of 10 reps with the compex on her quads when she does her quad sets. Started to introduce double leg hamstring bridge to load her hamstrings. She was going through her ankle, foot and ankle control with her ankle rehabilitation, and starting to do calf raises to work on that calf strength. The foot and ankle exercises composed of banded ankle inversion and eversions to work on her ankle strength. Starting to use the Blackboard, which is a great device that you can purchase online, which is really important for working that midfoot control. Her mobility circuit was her knee extensions and knee flexions, working on her patella mobs, where she's moving that kneecap up and down and side to side, tibial rotations, where she's rotating her knee side to side, and she would do this daily. In week 3, when she was able to return to the gym, she's doing banded TKEs for her quad, working on her run prep with her triple extension work. So this is where she's doing wall holds, wall marches, progressing on to using the leg press with less than body weight and occluded, single leg hip thrusts for her glutes, hamstring isometrics in a bridge for her hamstrings, seated soleus press for her calf strength, pull-off and front plank for anti-rotation with the pull-off, and front plank for her core, and then finishing with an occluded flush to help with swelling management. Her second rehab was very similar to the first, except we would also add in a barbell RDL for a hinge pattern, standing calf isometric to work on stiffness around the ankle, and starting to do some hip flexor work to work on her hip flexor strength, which is really important for running, which will occur obviously a little bit further down the line. And then during this time, she would then do a few extra sets on her opposite leg to make sure we're just topping up that quad and that hamstring, and that other leg isn't atrophying and getting weaker. And we're just simply doing this on the open chain machine. She's then doing knee extensions and hamstring curls on her unaffected leg. She was doing 4 sets of 8. This is just to induce a little bit of strength and a little bit of hypertrophy. She also had a home rehabilitation session as well, single leg balance, her inner range hamstring strength, due to her previous ACL injury where she had a hamstring graft. She's working on her hips with clams and side leg raises. In weeks 5 to 6, you'll see there's a massive shift in her program. She's doing a lot more exercise because she was in a really good place. She'd achieved all her markers, getting the knee straight, getting the knee bent, getting the quad switched on, getting her swelling way down. Because of this, she's able to then earn the right to progress on in her rehab. So she had compex, which is the maximal set on her quad. She then had her run prep, which is her triple extension exercises, her banded triple extension, hip lift, lock, and over. Great exercise to develop control of the stance leg, getting triple extension to the ankle, knee, and the hip. She then progressed on to doing a single leg squat variation, where we're keeping the knee behind the toes. We don't want the knee to go over the toes with the single leg squat for her at the moment because she's had the patella tendon graft. If the knee goes way over the toes, it puts way too much stretch on that patella tendon. She then got her single leg press, which is occluded using the compex, less than body weight, single leg hip thrust for her glutes, seated soleus press for her calf strength. And then she had an occluded circuit with a double leg squat where she keeps her knees vertical, a single leg RDL, a single leg glute bridge, and a calf raise. This is done in like a giant set, so the 4 exercises are all strung together one after the other with a small break in between. Then finish with her core, which is once again the pull-off press and the front plank, and she finishes with an occluded flush. For the final session of that week, she had her compex TKEs, so doing standing TKEs, going through her triple extension work, which is a run prep, and then into a very similar gym session, step down, single leg press. The double leg RDL is the main difference here. We then finish with the single leg cable kick down. Because we can't load the RDL super heavy at the moment, I get the patterning with the RDL and then get her doing the cable for the actual load through the hamstring. She's then doing a calf iso with the barbell and then doing some eccentric hammy work distally with the 2 up, 1 down, the prone hamstring curl machine. She's also got landmine rotations and front planks, and then finishes with that occluded flush. Charlie is a professional athlete. She's full-time with her rehabilitation. She is therefore able to put a lot of her whole week revolves around getting her rehab right. 3 main gym sessions a week is all you need to achieve a really good amount of load. They are spaced out evenly throughout the week to allow for enough recovery. The key here is the morning assessments. You're not getting more sore, you're not getting more swollen, you're not getting more stiff. and we just want to make sure that we're achieving progression each and every week. So guys, if you have any questions, please drop in the YouTube comments below. We will be doing an Alex Answers series where Charlie asked me questions from the YouTube audience and we sit down, we answer them so that we're giving back to you guys that are choosing to engage with us. So please, if you have any questions, drop in the comments below. So guys, thanks very much for listening. I'll see you next week.